Hello and welcome to SCAN, a show brought to you by SCAN, the Social Communities Activities Network. SCAN is a nonprofit agency dedicated to helping active adults stay informed, empowered, and inspired. I'm your host, Tracey Wolfman, and I am the CEO and owner of We Care Adult Care, and a board member here at SCAN. Welcome to SCAN offers information and insight to educate and inform you on the community that are available, as well as discuss our program offerings on-site here at our location on the lower level of the Monmouth Mall and at our satellite locations in Freehold, Keansburg, and Ocean County. Our guests will be experts who will provide you with the latest information. We hope to give you valuable resources that you may not have known of. I'd like to welcome my guest today, Sean Curry from Kindred Hospice. Excuse me. Welcome, Sean.
Thank you very much, Tracy. It's a pleasure to be here.
Thank you. So the reason why we wanted to have you on the show today is because I think there's a lot of misconception and myths about hospice.
That is correct.
Now, Kindred is a national company with headquarters in Louisville, Kentucky. So you cover the entire country.
A majority of the country, yes.
Okay. And we wanted to give people some valuable information so people are not afraid of hospice and the great services that it provides.
I think that's great.
Just to give our viewers a little information, Sean Curry here is the marketing manager with Kindred Hospice for the last 4.5 years, and his job is to help patients and families navigate through the process and to make sure everything goes smoothly as possible.
That's correct.
Sean is a native of Point Pleasant Beach, right here in Monmouth County, and he's going to talk to us specifically on what is hospice today. So tell us what hospice is so people don't have this misunderstanding.
Sure. Well, the definition of hospice is a specialized form of care for patients that have what we call a life-limiting illness, that a physician would say that with that illness and no curative treatment, that the patient has a life expectancy of about 6 months or less.
Right.
The patient would have to choose more of a comfort treatment as opposed to curative treatment, and they have to want to have hospice. This isn't something that someone can say that you have to have. But ultimately, it's just an extra level of care for not only patients but families wherever the patient resides to take care of their spiritual, emotional, and physical needs associated with a terminal diagnosis.
Right. Now, so many times people think that hospice, you're in the hospital with an illness and you're going to die tomorrow.
Yeah.
So from a perspective that I've seen hospice used, I mean, people have gone on and off of hospice throughout their diagnosis. Now, if we were to say that there is myths of hospice out there, I think that's an understatement.
Okay.
And I would really like the viewers to understand and be comfortable with this as an option and choice of care at the time of need, because you don't have to be you could have a diagnosis of something that is an ongoing chronic disease also, correct?
That is correct, yeah. So what I will tell you is that when we meet with a lot of patients and families, they think hospice is either a place to go,
right.
They think hospice is just for patients with cancer, and they understand and think that hospice is for someone that has a week or 2 days left to live, and it's really not.
Right.
You'd be surprised how many times we meet with families and patients and discuss our services, specifically in the home setting. And what they say to us is, we wish we knew about you 2 or 3 months ago, because
right.
we've needed the help in the home. For us, it's just getting over those myths that when we come in, we're going to stop all medications, we're going to come in and support the dying process. We will support it, but we're more about living as opposed to dying. And we're about the quality of life for that last chapter in that patient's life.
And I think that's what people need to know.
I think so too. And we've had patients on service for an hour, we've had patients on service for even years. And for us,
right.
It's just allowing someone who is eligible for these services, whether under their Medicare or insurance guidelines, to be able to benefit from the services that are out there.
Right.
And for us, it's just so many times it's an eye-opening experience when we meet with these patients and families that say, wow, what's the catch? And the catch is, unfortunately, that there's no true aggressive treatment. And for us, it's just saying that if you're in that point in time where you're looking more for comfort as opposed to curative, our team or hospice team is right for you.
That is wonderful. What are some of the other myths besides misunderstanding what the services are?
I think, I'm sorry, go ahead.
No, I was going to say, because we know that the person doesn't have to be dying tomorrow.
Correct. I think what people look at is they think it might just be for patients with cancer. And you look at any sort of a life-limiting illness, which could be congestive heart failure, it could be COPD, it could be Alzheimer's dementia, it could be a whole mixture of those things.
Right.
As long as we can work with a physician to say that this person might pass within 6 months without aggressive treatment, that person can benefit from the services and the team approach that we can provide.
And when we think about the 55 active adult right now, I mean, they're active. They may have a debilitating disease that they're just tired of treating, or they may have a new onset of a diagnosis that they're opting not to utilize the treatment for. So when we think about, it's not the aging category. I mean, you could be as young as 20 or younger, and up to, you know, your...
I agree. I mean, in the past year, we've had someone who was on service who was in his early 20s, and we had someone who was 104 years old.
Oh,
so
see that?
For us, when I hear the word and the age of 55, I think about it might not be that person that you're talking to or that we're talking to right now. It might be a loved one of theirs.
Correct.
A majority of our patients is pretty much the age of 85 and over. And those are the people that have gone through life and got to a point where they might not want to go through all the aggressive things that people are either asking them to do or that they might want to do without knowledge of what we can provide at home or wherever they reside. So we think about a lot of times, I'll even meet with a physician who's talking with one of the patients in front of them, and they're talking about their mother or father that lives at home. And those are people that we can definitely help and help educate as to the services that we can provide when that time is needed.
Right, and I think the misunderstanding, I always say that they need to change the term of hospice because it's been around for so long, and people just have a barrier up to it, when it can be such a great, fulfilling time for any family or loved one. And I think the myth of, you know, it being a bad thing needs to be removed. So I'm so glad to have you here. What are some of the services? Because people think you're just going to go in there and sit, and I know that Kindred, as well as every other hospice, provides a multitude of services. So what are some of the services that you provide under the hospice?
Sure. What we would like to talk about our services in regards to hospice care. It's based on an interdisciplinary group, which is led by a hospice medical director.
Okay. Some people might not know what the interdisciplinary group means, so if you could just elaborate a little bit.
We like to call that our team approach.
Okay.
So it is a team approach led by our medical director. What you can expect with hospice care is a nurse case manager to visit wherever the patient resides, whether in a home setting, a skilled nursing facility setting, an assisted living setting, or wherever the patient lives. You're supported by home health aides who can help with any daily needs as to bathing, helping eating,
Right.
maybe some light work around the house. It's all based on what we call a plan of care. You also have a psychosocial team, which is worked through with a social worker. We have pre and post bereavement support, and we have some spiritual support, which is non-denominational usually, and what we just talk about is the person's life, the family's life, and how we can best support them, once again, on the clinical side, but also the psychosocial side. And when I say that, sometimes families have come on, they haven't talked about funeral arrangements.
Right.
They haven't talked about an advance directive. They haven't talked about any last wishes that they might have want. I would say for us, we just had a gentleman on service who was a photographer his entire life.
Wow.
His last wish was to go into the New York Botanical Gardens and spend a day there and take some pictures and have a nice lunch. And based on our services, we were able to do that for him. And it's little things like that
wonderful.
and little nuances like that, that when we look at the team approach, you're going to have so many more eyes and ears on not only your loved ones, but to be able to help you. It's really, what I've heard yesterday was a godsend to a family when we were able to get in there. I would be remiss to say that our services are available 24 hours a day, 7 days a week, 365 days a
Right,
year.
and I think a lot of people don't know that, because I've utilized hospice for family members of my own and for extended family, and also in my career as a nurse. So people don't realize that 24-hour care that is available just by picking up the phone.
Yeah, and I think what happens, and we even talked earlier about over the holidays, where people say, you know what, I've come and visited, Mom's taken a little bit of a turn, I need help, it's Christmas Day, how can we help you? So it's just an opportunity for us. We're not hospice providers are not a 9-to-5 job, it's a 24-hour, 7-day-a-week job.
Right, and which is a great comfort to somebody who, they're not going to be calling their doctor at 3 o'clock in the morning.
Correct.
But they can call you.
Exactly.
So there's some other services, because now you've talked about the medical and the oversight of your whole team. But what about the extras? Because I've seen pet therapy be brought in, some music therapy,
Sure.
things, pastoral care.
I think what every hospice provider looks for is how to present and give that extra little care, more on a holistic approach. And when we look at our music therapy, we look at pet therapy.
Right.
We look at opportunities just to have patients and families talk about what their wishes are. Different providers provide different things. I've known that there's been companies that walk around with a harp to provide some nice soothing music.
Okay.
I know there's companies out there that provide disposable headphones so that when we're providing care, they can have whatever music they really like. I think there's also times where we meet with families, specifically with those with dementia, and talk about what was this patient's life before and how can we better serve them, knowing what they did for a living and knowing what their favorite things were and knowing what books they liked, because I think that's important to really look at the life as a whole as opposed to where the person is today, and how can we better serve that patient and family with their history and what made them happy back in the day.
Right.
It might be a smell of corned beef on St. Patrick's Day, or it might be just a little thing of songs that they liked that really adds to that quality of life.
The interesting thing is a lot of people sometimes don't even have those answers, and they learn them through the process of hospice, because I've seen it done numerous times, and it's so interesting. You would think that would be something that people would discuss.
Right.
Along with advance directives and funeral arrangements. So, and not to be premature about it, but I think people need to talk about those things even when you're 30, 40, 50, when you get married.
Yeah.
I mean, there are important decisions that I think in the past have been taboo subjects.
Sure.
And now that people are more open and let your needs be known and let people know where those documents are.
It's true.
Because lots of times you can't find them.
And I had a personal experience last summer with my mother, who had some challenges, and it took for her to have those challenges for my sister and I to really sit down and say, where are we, where are your wishes, and how can we help you?
Right.
And we learned a lot about not only each other, but our entire family, about the support that's needed. A lot of things that were challenging to my mom we learned, and it took a little bit of a health issue to happen. So.
And it's a good conversation to have.
Sure.
So when people want to push it aside, I encourage them to speak about it now, but I think once the team approach comes in, it's always good to have those conversations. Know where those documents are. People say they're in the safety deposit box.
You have
know
to
know
where the key is, yeah.
You have to know, well, and then you have to know where the bank is. I know a family, they went to every bank and they couldn't find it, but lo and behold, it was under the wife's name first and not the husband's name. So every bank they went to said that it wasn't in that bank. And then when a year later they got the safety deposit box bill, they were able to go back and find, but then they had already probated. I mean, it was a big process.
Yeah. And there's a lot of challenges when that time comes, and that's why when you look at the team approach that we spoke of, that sometimes the social worker and their talents can help and just get everyone together, look towards that common goal of excellent support, and answer a lot of those questions, I think is helpful. And
I think having various sets of eyes and different levels of caregivers and resources in the house gives a different perspective to each. It brings new meaning to each family member that's in there, because the assistant may say he really likes to face the window side.
Sure.
Or she likes the smell of flowers.
Sure.
So those kind of little tidbits, and then you have the physician who can tell you the medical component of it.
100%.
So those are all interesting topics. So we have a good idea of what hospice is now, some of the myths of hospice, services that are provided, and we're going to probably go to a short break now and come back and talk about some other helpful hints for these people.
You got it.
So we're going to take a short break, and we will be with you right back after this message.
So, if you're over 65, like me,
and active and fairly healthy,
being active and healthy alone will not protect you.
Remember, the immune system weakens with age.
And if you're over 65, ask your doctor about your vaccination options.
we want you to be healthy and active.
Welcome back to our Welcome to Scan TV show. I'm here with Sean Curry from Kindred Hospice, trying to alleviate some of the myths of hospice and what a great benefit it could be to some people. So, Sean, we're back again. We spoke about what is hospice, some of the myths of hospice, services that are provided, and now I think just to eliminate some other misconceptions, one last thing I want to talk about is, where is hospice done? People typically think you have to be in a facility. So tell us the different variety of places that hospice is provided.
Well, I would say that it's a goal of any hospice provider to bring care to wherever a patient resides. So a lot of times we would be in a patient's home.
Right.
We can also provide care at a skilled nursing facility, assisted living facility, even a senior residence. So what we find is that we identify where a patient is first and foremost safe and where they want to be, and we try to accommodate having the services provided there. You'll find that a majority of the patients are going to be home or in a facility at that point in time. Also be in an acute hospital or even an inpatient hospital setting.
Okay, so people, if they are in a hospital setting, they can have it, but most people like to be in the comfort of their own home, and you can do it whether they're in long-term care, assisted living, senior residence, or their private residence.
That is correct, yes.
That is a wonderful service.
Sure.
So we have to know that you don't have to be in a hospital.
You don't, and I think that's one of a lot of the misnomers, is that people think they have to go somewhere to get the services when we can bring everything there. And I also like to say that with hospice care, we become the 911 call, and we can do a lot of the things that someone would have to be done in an emergency department. We bring the care to the home, so that allows them to be able to be safe, be home, and not have to go into that emergency department, which I'm sure everybody knows is a tough place to go at any time of the day.
It is a very tough place to go.
It allows people to be safe, to be comfortable where they live and where they age, and we like to allow them to live in place, which I think is a goal of many of the families that we deal with.
Right. I think it's everyone's wish, because nobody wants to be in the sterile environments, right?
Yeah, a lot of beeps and boops at 2 o'clock in the morning.
Oh, yes. So how does one go about choosing the right hospice provider?
I think what you should look for, and this is one of the biggest things, is that so many people are pushed in a direction and they don't realize there's a choice. So what I would suggest with a lot of the families that are looking for services, Medicare.gov now has a fantastic hospice compare, in which they look to say is, just like they do with a lot of the nursing homes in the area, they've done surveys, they worked with families, and they said, how did this hospice provider do with things such as, did they explain the services correctly? Did they explain things about having pain and being short of breath, even bowel protocol, which is a lot of the pain that a lot of people with opioids feel at the end of life.
Correct.
So what they've looked at with families is say, how did this provider do with discussing these things? And it's a very simple click of the mouse. You can go on Medicare.gov and you can look up certain providers, because I feel so many times people spend more time researching buying a new car than they do on researching buying a company that you're providing end-of-life care to. And I think it's who of everyone to understand that there is a choice in this world, and that you can go out and research and interview 3 or 4 companies, have them come in, have them talk about their services, have them talk about, am I going to stop this medication? Am I going to keep this medication? What would you do at this point in time? There's a great questionnaire you can have, which Medicare.gov puts out there to say, when I'm interviewing companies, these are things you should be looking for.
It's interesting when you just made that analogy about the car and end-of-life care. People will spend so much time buying a car. Exactly right. They'll investigate, they'll research, they'll test drive.
Sure.
And then they don't really seem to research so much on end-of-life care. That really is hitting home with me.
I would also say, too, talk to family members, talk to people in the community and say, have you had a hospice experience? And a lot of times those that have a great experience will tell everyone how great it was.
Right.
So you can get a recommendation based on that. And once again, I would just interview. I think it's a great opportunity to learn about the different companies and the different providers that are out there.
Right, and what they provide.
Sure.
So now that we've gone through all of this, everyone and the inevitable question is, how much does it cost and how do you pay for it?
That's fine. So majority of our services are covered through either Medicare, Medicaid, or private insurance companies.
Okay.
I would say that based on the fact that the majority of patients are over the age of 85, they are going to be Medicare appropriate. Everything associated with a terminal diagnosis is covered by the hospice provider under Medicare Part A.
Okay.
So what you'll find is that when we are electing the benefit, or excuse me, when the patient and family elect the benefit of services, everything associated with that terminal diagnosis, which includes any medications associated with that, any equipment needed in the home, and any supplies needed, plus the team we spoke about, are now covered by that provider of choice.
So the services, they'll bring the equipment in, they'll pay for any, say they need a suction machine or a hospital bed or things like that.
Yeah, so you're going to look at a hospital bed, you might look at a commode, you might look at a wheelchair. When you look at supplies, you look at the diapers, you look at the swabs, you look at a lot of the bed sheets.
That are very costly.
They are costly, and I think when you look at someone that might have been incontinent for years, that growing number of a per day cost for supplies for your loved one, it's very, very high.
So these are covered under typically Medicare, Medicaid, and if you have private insurance. So that would make me assume that there's really no out-of-pocket cost if you have some sort of health insurance or are on Medicare or Medicaid.
That is correct.
Okay, so you can have the comforts, you can have the service, it's a covered entity under your insurance.
It's just an extra level of care for your loved one that needs the help at that specific time.
And that they can stay home and have great oversight by a team of people who care for them.
That is correct.
Now, volunteers are something that I think have been very well used in hospice.
Mm-hmm.
So what do volunteers do for hospice?
So volunteers for any hospice provider is just an opportunity for people to be interacting with the patients and families that we have out there. So you have some volunteers that, once again, we talked about, have pet therapy. Mm-hmm. We have some veterans that volunteer for us that like to go out and meet other veterans. So as you know,
nice.
A lot of veterans are getting to that point, specifically World War II or over that age of 85, where they would like to maybe talk with someone that had lived with them. And not just World War II, but you look at the Vietnam, the Korean War,
right.
And even that. But I think when we look at how the veterans are out there, I think it's important. Just sometimes people just want a companion, someone just to maybe go out and shop for them a little bit. But I would say that every provider is looking for volunteers. The volunteers are part of the backbone of a great corporation, and they could do as much as go in the office and help with some paperwork, or they can actually go out and do some help with the patients and families that are out there, maybe sing some songs or just talk about life. And it's very important to be able to have volunteers that can help.
Right, and be that friendly face. So number one, it's a great use of somebody for volunteer service. So if we have any people out there that would like to volunteer, call your local hospice and see if you can contribute. One of the other things I just want to touch on briefly before we close out here today is, so we know about cancer, Alzheimer's and dementia are a big thing now. What are some of the other illnesses that people have that may consider this as a choice, whether it be early on or later on in their progress?
Well, I think when you look at a lot of the common diagnoses, you're going to come up with a cancer diagnosis first.
Right.
Second will be cardiac issues, congestive heart failure. Cardiac issues are very, high up there, and pulmonary issues. So COPD and a lot of those where someone might be oxygen dependent. There's a lot of things that can just attest to that 6 months or less, which I think is really the key for our services. You might look at some indicators. So some people have, reoccurring UTIs, which are urinary tract infections.
Right.
Someone in and out of the hospital, someone who's what we call a frequent flyer, in and out.
Right.
What are they doing there? Are they staying for a couple days, going back with the same issues? Are they having troubles when they get home with the instructions that were given to them by either a hospital or the doctor that got them there? Where is the help really needed? Sometimes we go into a setting after hospitalization, and we're there to help set up the pills for the next day, and we're there to help and make that phone call that when they might need help at 2 in the morning, instead of calling 911, they call us and we're able to provide that care. You look at multiple falls, you look at a lot of those things that kind of click in your mind that we might need extra help in the home. And that's when a lot of times people call us and say, can you come out and evaluate? I think an evaluation's key. It allows people to understand, based on a hospice's coverage, where are we
and
today?
Guidelines.
And guidelines. And there's some times where we'll get a referral from a physician where we'll go out and meet with the family, and that person might be not as far along in the prognosis that other people think. But what that allows us to do as a provider is have a baseline and say, okay, when this happens, give us a call, because then then you can really get the services that we can provide. And those are usually families that are benefiting from us with months of service as opposed to just days or weeks.
Right, and then they can have an understanding of what you're providing also because they have already spoken to you. One last thing, people can come off of hospice if they recover. So, and then if things decline again, they can reestablish that. So just, can you touch on that for just a bit?
Sure. Well, we find it's, hospice is for someone that when that initial eligibility comes through,
Right.
They're at a point in life. And sometimes people thrive on hospice. Sometimes it might have been a quick thing that happened and they plateau out for a long period of time. If they either plateau out or don't get worse, we can no longer keep them on service. So they would have to be discharged. If someone's on service for 6 months, they'll have to have what we call a face-to-face meeting with a doctor or nurse practitioner. And if they have declined from that initial day, they can continue. That has to happen every 2 months after. So for those people that have declined and then have been on service for even a year or even more, some people have gone on and have come back on and back off.
Okay.
So there's opportunities. And I like to say that once you make that decision, it's not set in stone that this is the last thing for you. You could choose to maybe do some aggressive treatment and then come back on. So there's a lot of things above and beyond, and it's not just that point right there.
Just as long as they have that understanding. Sean, I can't thank you enough for coming on our show today. I think you've given great oversight into what hospice is and how people can benefit. I want to thank you so much for tuning in to Welcome to SCAN. I hope that you've enjoyed it and learned some helpful tips. Now it's your turn. I'd love to hear from you and what's on your mind. Please call SCAN at 732-542-1326, or you can email us at www.scannj.com to send us your show ideas. And until then, thanks for watching, and thank you, Sean Curry from Kindred Hospice, for being on our show today.
Thank you very much for the opportunity.